Afternoon. This is Abdullah Shaheen. This is our third lecture, AI in clinical practice, and I'm all sure you are here to know who and how we are going to lose our jobs to. So, because this is a lot of kind of hype and talk about how this is going to disrupt and how many jobs are going to be lost in the white collar, blah, blah, blah. So, it's good to actually know where things are and how much time we have. So, this is a nice haiku that I remember learning when I was learning Japanese. Waga inochi igugaku ga aru yoru mijikashi. My life, how much longer do I have? The night is short. And there's a guy, his name is Basho, and is very dark with his poetry. And we are all kind of feeling this, seeing some of the changes around us. We are imagining a point where we're going to be seeing something like this, and this is going to be your doctor seeing you for the visit. And news hypes and the news titles do not help, especially when you see something like, oh, an AI just beat human doctors on a clinical exam, and so, and like a lot of uh, these models that are trained and actually beating us with USMLEs and all these tests and the board exams, and we're thinking, oh my goodness, we are going to be replaced very, very soon with these algorithms. You see all these ChatGPT diagnoses that all the physicians missed, and some patient actually prompted them and got the answer. So there's a lot of that happening nowadays, and it's all valid, but also has some context to what's going on. So by the end of this lecture, we would talk about, we would have learned about the role of AI in clinical medicine at the bedside as a diagnostic tool, some administrative application of the AI tools that we have today. And when talking about these, we would have covered some of the basics about what agentic AI tools look like and how to think about them, and some of the pitfalls and gaps in AI in healthcare in these applications, and where we are now and what's next for us, what's going to happen in the horizon of our specialties. So I have no declarations of conflicts of interest to report, and we'll start with AI in clinical medicine. So this is a nice graph from the National Academies of Science talking about the cycle of healthcare process. A patient gets a health condition, experiences it, long enough, he suffers that he goes and engages with the healthcare system. And then we go and put that patient through the information integration, interpretation, collection cycle that starts by your history and examinations, and then the diagnostics and some referrals, which leads to more history examinations and tests and so up until we end up finding a diagnosis or a list of diagnoses. We try to communicate these diagnoses to the patient, try to come with a treatment plan, and then we try to measure the outcomes. So for a lot of the data scientists, they look at this and they salivate and say, I can do that with an algorithm. Let me build something to do that for the physicians. Let me actually do something that will actually replace the physician, because it is a straightforward process that we can actually automate 100% and go to the next job. And this is the Ragoti's hierarchy of needs for AI. You need data, a lot of data. You need them storage in one place or an accessible place equally for all uh, uh, parts. You need pipelines to bring that data to the model. You should have some business intelligence that tells you what you need to do. And this slide exactly kind of outlines, in a sense, what we do with healthcare information and how we actually utilize that to reach the next steps. And then some data science, someone who is actually going to be able to say, we're going to use this module, so, and then build the module and then integrate as an AI service. And this is how we're going to work on. However, we have a huge issue with our data in healthcare. Healthcare data, as we have it today, is very dirty, meaning the quality, the cleanliness of this data is horrible, that even us do not trust it. I'm not sure about what you have in your record, but our physical exam documentation is nonsense. I've seen patients being discharged, and the last note that they said intubated on sedation, because it's been copied forward for so long. And you'll have 5 exams from that day from different specialties, each one of them having a very different cardiac exam. Maybe one actually detecting a murmur, and the other having no idea. One says regular rate and rhythm, and the others will say AFib. This is in elderly patients. I'm sure you've seen it with your neonatology that people might not be as consistent with their physical exam. Some people might miss parts of the documentation, and this is not the only part. It is very inconsistent in a sense that you cannot know retrospectively when you're looking at the record what was the state of the patient very clearly. And also, we don't have full data sets. You do not have sensors on patients that is longitudinally documenting every single moment what these measurements are. And when they encounter healthcare, they do not get a one size fits all approach that you say, oh, now that they came to the hospital, we have a full set of data for them that I'm able to use that and contrast it to the next encounter, to the encounter after to say, okay, at least I'm getting like like a kind of a longitudinal point or horizontal point to say what was the situation now in a comparable way to the one after. So our healthcare data is not complete, and the context in healthcare is always missing. You can think that the diagnoses from ICD-10s actually reflect why they were in the hospital, the admission diagnosis, the discharge summary, and so and so. But again, the events inside these are very hard to tease out what kind of context they have because it is very complex and it's harder for you to translate into data points that can then help the machine learn what they're looking at and get insight and replicate it in a bigger data set and then say, when I see this, I'm going to predict that and go to the next level. So again, good AI needs data, and we are actually at the bottom of that hierarchy of needs for AI. And that is why we actually have a lot of work for us to go before to get to the point where we're actually going to be able to have a decent assistant, not only the physician like. So any algorithm that you train, you are trying to get a couple of things. One, whether to treat. You are trying to use this to diagnose, and this is what they are trying to validate for. And this is basically data classification. I'm going to say, looking at this data set for patient X, which is row 412, I'm going to try to say they fit A, B, C, D category of whatever diagnoses you are trying to differentiate between. It also tries to predict, prognose who is going to be discharged from the hospital, who has a higher 28-day mortality in the hospital or outside of the hospital, 90-day mortality, who is going to need this care or that care. This is the prognosis prediction model, and you can do that. And you also try to see, okay, how to treat these data sets to say, in this scenario, the treatment actually helped, in this, it didn't, and try to look at what is common and uncommon to say, I'm going to try to do that. So all these are on the science level of what you are trying to apply data science for in AI. However, on the practice level, classification and getting a diagnosis does not necessarily always help you to know what to practice to go next with this. Also, with the prognosis, let's say I was able to diagnose this very weird disease and also give it a timeline. How am I going to translate that into an action on the patient? And what kind of measurement outcome I can do? And how can you actually then scale it up on a population or on an entire city or an entire community? And then that's how the delivery part. Am I able to actually replicate this on all the patients I'm trying to do? Is it something that actually going to be able to be applicable for everyone? Like if I now get a prediction model that if you wear this wearable for 28 days and you come back to me, I can translate that data and tell you when your mortality is going to be. How is that going to be helpful? If I get a diagnosis that I predicted 6 months in advance, what do I do meanwhile? I know this patient has a risk of colon cancer and this colonoscopy and the CAT scan are negative. How is that going to help us figure out what to do? So these are practical issues that we need to deal with as we are getting these machine insights. And you also have this kind of utility over time. The cumulative utility is going to reach a point where afterwards this becomes not that helpful because the AI guided work is a triangle of the model that everyone is excited about, every news article talks about. But then what type of action, we kind of discussed that, and also what kind of policy we are going to build based on these insights and these knowledge that we have added and the capacities that we're going to be acting under. Like if you know that this is a person who has an increased risk of mortality, do you actually enforce a DNR situation on them? Can you do that? Can you not? Would you actually decrease the amount of hospitalization you offer them as part of this insight? Is that even ethical? These are all stuff that the model has no hand in. It is in your hand and in a bigger system's hand to actually deal with what you get from that insight from the model. And from one of the lectures in Stanford, I got this slide and I actually took a screenshot of it because it was interesting where they actually used AI to create an AI-assisted EKG reader for the ED. I mean, these are high frequency encounter areas. They do a lot of EKGs, and they said, okay, we're going to develop something that helps physicians read EKGs more effectively. 10 years after, and almost $28 million into it, they were able to build that. And so they were able to get this model. But how much impact did it have on the time to read? That was not something that was thought of very well. How much actually did it help the physician who was going to eventually look at the EKG themselves and use that insight that the AI gave to care better for the patients? Were there any outcomes that was different? Also was not very well validated. And then how much would I use this AI and what is it saving me to justify a $28 million cost for that? So all these stuff are very important as we're thinking about AI development tools. And that's why you're going to see a lot of AI applications today, but it's going to be on stuff that are low hanging and stuff that are appropriate for their use, but they're nowhere of replacing anything meaningfully. And you know, in your practice, you probably get this hint that the story of the timeline or the process of you developing your diagnosis starts with the data acquisition from the patient story, maybe searching more, maybe asking more questions, coming back to them, and then you try to formulate a problem representation. This is what you digest into what is similar to an USMLE or an MCQ STEM. Okay, this is this age, this gender, these medical problems, these kind of scenario, like series of symptoms, and these are series of labs. And then you generate a hypothesis, most likely this diagnosis. Or these sets of diagnosis, this organ system involved, and then you try to look through the illness script, and then with your workup, with your additional data acquisition, you try to reach a diagnosis. CT, positive, negative, these blood tests. So there is a component of knowledge to this, absolutely, but it's not enough. So no matter amount of data you can get, the insight that you're gonna get is limited if you only get into the knowledge. And you see this with if you have a medical student running with you and they see a case of whatever condition you have to deal with, seizure in a baby, they will be proposing all these different differentials that on paper look decent, but you then put in a context, it doesn't fit. And with your experience, you know there is not the diagnoses are not equal. I mean, you will probably see more febrile seizures than actual pathological ones. And then, but for the machine, for the student, it's an equal opportunity until it is weighed by context and until it's weighed by experience. And then that differential starts to shift a little bit towards one versus the other. And this was a very nice paper to come across, titled Deciding Without Data. And this was done with physicians, mostly work, I think, pediatric cardiologists. And they looked at a week worth of their work, actually a week and a half, because 5 days is a week. And they measured or documented almost 1,200 decisions that was made. 80% of these had no published data about them. This is how complex the context we deal with. Less than 3% had something published that can actually guide you towards the right treatment and the right steps of working them up. So you deal with very unusual scenarios every single day, even when the diagnosis eventually is the same. The context that they come through is very, very hard to actually put in a kind of a step-by-step algorithm or data flow sheet to and make a decision based on it. Impressive that 80% of the stuff they actually ended up making as decisions had no prior published data. Like, we think we have tons of medical literature. We actually don't have enough, and this is it's hard for us to even believe, but that's the true nature of medicine. So our real work is actually how we're gonna go to execute on what the algorithms are telling us. Because yes, we are getting all these nice algorithms that gives us insights. How you actually integrate these into your decision making, into the next step, into the policy is a different thing. And also how many actually have the data to generate a decision for to help you. We really don't have enough data to make that a universal physician kind of style super AI. So let's go and talk about AI at bedside. I'm going to talk some applications now. So the first one is the first encounter, the AI clinical intake. These are the most commonly used AI agents nowadays in clinical practice, believe it or not. Whether it's your physician's office, if you're in the US, the CVS and Walgreens and all these prior to arrive check-ins. These are all AI clinical intake tools. They streamline the processes. It's very fully automated now. It reduces the wait time. You walk into the clinic, you don't have to get that chart and start checking boxes or writing stuff and putting your insurance information. It's already done there. So it's much faster to do them too, because they have a profile most of the time. So you don't have to keep replicating data. The data is accurate because it's typed in and it's validated. It's a checked box. It's not something that they're actually going to scribble on the piece of paper. It reduces error and improves data quality, which is, again, the tool and the fuel for good AI. So it's a self kind of a propagating a virtuous cycle of improvement with these tools. So these actually do more than just intake. They actually start adding other parameters of what they can actually help the visit to tailor towards by asking a few questions, asking about whether they had COVID-like symptoms or not. And so it helps you with triage, it helps you with planning the next steps of care. But it does not come without like pitfalls or problems. On the top being data privacy and security risks. It's becoming so annoying in the US getting all these emails, whether it's your bank or Target or all these clinics saying, oh, sorry, we actually had a major data breach and we might have lost this, and that. So you are dealing with the most sensitive data set you can get on anyone. And having that becoming something that is exposed to that threat is a big problem. So that cybersecurity is very it's nightmarish to us because yes, you're doing all this great data collection and getting all these insights, but then you're putting people at jeopardy, literal lives at jeopardy. Cost and implementation challenges. You have to invest in technology. While we are living in a first world advanced countries with good resources, that's not a universal thing. And even in these settings, it is different from when we talk about big hospital versus a standalone clinic. Integration to your other computer systems, whether that's your front desk management, your lab management, your physician EHR, It is not easy, and it's always a kind of a hurdle to overcome. And how much return on investment are you getting when you actually are saving the patient a few minutes of the waiting time and getting better data? It's not equal for everyone in terms of how much they get on the return of the investment. And then you still have to have oversight and accountability. Over reliance on AI will actually lead to some of the technical special kind of knowledge loss, and there are accountability gaps on what you actually are doing or not unable to do with this rigid structured system. There might be something else that they need to communicate or something else that you should be sensitive to, and there's no way for them to actually guide the algorithm or the clinical process towards. And of course, everything that has AI has a lack of transparency due to what they call the black box effect, because you don't know how the algorithm is working. You don't know how it's reasoning. You only know that you put something and you get an answer. And this is a big problem and is being worked on from different parts to see how we can actually increase transparency in AI. And there's some small achievements, but we are far from being able to see how it's reasoning and then seeing if it's reasons well or not. And of course, data quality issues, because again, even when you are digitizing that, it doesn't mean that they're going to put the right data. They might be putting NA everywhere, so, or a dot just to move on. Patient acceptance to this additional or different kind of a role they're playing with. They are now data administrators. They actually enter data for themselves, and there's always regulations involved to this. So these are tools that are actually being implemented broadly in different settings. They are helpful, but they also come with a cost. I'm mentioning these platforms is because I actually ran through them either through pitches or through Google searches, and some clinics actually I have visited. And so Frisia, Mend, Luma Health, Next Health, Solution Reach, all are available to kind of subscribe to, and the cost is between 50 to 100 to $200 per month per provider. So they're not cheap per se. I mean, the $200 prescription for a physician is not an easy sell for this kind of technology, and especially if you're talking about maybe actually for a single clinic have to register more than one provider, so the cost actually grows exponentially with the amount of people touching that platform. So now talking to about the ear, hearing, ambient AI transcribing tools. Another amazing technology that over the last 2 years have exploded. I mean, exploding. It's a low-hanging fruit. It's easy, especially if you're talking about English. We have models that are very well trained to actually translate and transcribe even people with me who speak fast and have an accent. Uh, Speaker identification has become amazing. Medical terminology accuracy. I know if you use the Dragon, I mean, it drives me crazy when it actually takes one word and transcribe it very differently from what I'm trying to say and kind of screws up the entire context. But nowadays, these actually have context and have medical terminology correction, and they know the right words to actually use. They are almost all EHR integrated to a sense. They have voice commands that actually can help them put orders or take active measures during the visit. And they now support multi-language. Spanish. A friend of mine is actually developing a platform called Vita Health, which does English Arabic. So amazing. Editing and reviewing controls also are kind of getting better with it, but might highlight an area that they suspect that they might have not heard it very well, or a missing word. And you can use custom templates where it's going to digest whatever it heard, put it in your template that is kind of billing consistent or like a compliance compliant with whatever format you need to do, and then you just review it and sign it, and that's it. That's the end of your clicking. Amazing technologies, and it is saving time between 30 and 40, 50% of the administrative time we put on notes. So you improve efficiency and you shift your focus to the patient again, because over the last 15 years, it's been hellish nightmare for a lot of clinicians having that computer in that room where their back might be to the patient and just typing in while the encounter is taking place, and really reducing burnout among physicians. Documentation complexity is now getting better because now actually you are able to just by taking that history to transcribe a more detailed history than you would have typed or dictated later on. Same for the exam. Now you mentioned, oh, your seems to be tender here in your abdomen. Automatically translates into abdominal tenderness on the exam instead of all these kind of stamped uh, 10 system exams that are almost always not updated or corrected, and improves your patient overflow. So you don't because now workflow because now you don't have to stop, put the orders and do stuff. It's already kind of put there for you to review and sign and push to the system. So it certainly is something that is now already at place, already working and doing amazing work. Softwares, again, they are exploding, but they're not cheap. They cost on average about $1,000 US dollars per user per month. Now, there's one that I came across called Tebra AI, and I want to actually go check it out, but it actually charges per note, which might be reasonable. So it's you pay as you use, and it's $1 per note. So it's only going to get cheaper. It's only going to get much more affordable. The one my friend is building is actually for free, and we can, if you are interested, that we can put you in connection because again, all these are still relying on physician involvement to improve their outputs, to improve the way they work, and they're gonna continue to self-improve because now it's getting cleaner data than we actually would have put in the notes ourselves. Another era application is AI-powered stethoscopes, and now this brings some pain to my heart because one of the first startups that I tried to work on was an AI-powered stethoscope, and of course our team fell apart and we couldn't do it. But now we have more than 10 companies that have produced amazing AI-powered stethoscopes. They are detecting murmurs. They actually can detect acute heart failure early on, detect atrial fibrillation, which is not that hard, but also they can detect some sort of cardiomyopathies, validated for peripartum cardiomyopathy detection. It's very easy to put in places remotely from you and actually be able to listen to a patient's heart while you're actually not in that room. The devices are portable and they actually are integrated well to many systems. They help you with early diagnosis. They can decrease mortality, decrease hospitalization, improve quality of life. They actually are working on getting these to detect and quantify ejection fractions, and so they are amazing tools nowadays. But also they are coming with the cost. I trained in infectious disease, and my mentor, uh, he rest in peace, Dr. Stephen Opel, was fond of murmurs, and he used to challenge us in how to examine and actually elicit the clinical murmur and put it in the context, and then getting what the differential diagnosis. So it used to be something that clinicians bragged about, enjoyed doing, and that skill, if you lose it, you're not going to get it back again. And you can see it where it differs from one system to the other. I've attended medical missions with physicians from India, and their masters in reading chest x-rays. They can get so much out of it that no physician in the US, even if he's a radiologist, would have gotten these. So that dependence on technology will actually cost us some loss of human experience, expertise. And that again, it's one thing that you don't want to trade in. We said knowledge, context, and experience. And if you lose that, you become less of a helpful person, and you actually open the door for more automation to actually come and take your place because now you don't have any experience to offer on top of whatever they're gonna throw at you. Of course, there are easy to introduce bias, and the limitation to what it actually does. There's a black box nature, generalization issues where physiologies are not equal. Patient who is bigger or smaller in size and obesity. These are all things that make the difference in what kind of reading you should be able to universalize on. You have issues with malfunction, noise interference. Again, if you're trying to get a sound signal, we're not sitting in a vacuum, so there's a tons of sounds around us. Data accuracy is also another problem, and data privacy, validation, regulation, and the cost is not necessarily very high for a first world country. They actually range anywhere between 400 and $1,000, depends how fancy you want to go with these. You can buy a decent stethoscope for 20 bucks actually, and you can buy a nice Littman for 60 bucks. So they are costly, but they're not necessarily cost prohibitive to us. But for a third world country where people actually don't earn more than $100 per month, these are not necessarily easy to kind of get their hands on. And of course, you need some training to know how to use this because tech savviness is not a universal thing. And you have physicians who are on the older part of the age spectrum, and they're gonna need some training to actually be able to use that. So these are all limitations, and people might not be using them appropriately, anyways. So now on the eye front, we're still kind of blinded in how to use AI help in a helpful way. There are multiple applications in terms of, okay, how can we augment vision in the OR? How can we improve the skin diagnostics using this? How can we improve detection of cancers using AI? And we spoke about many of these in our first lecture, so I'm not going to waste our time on them, but they are not here yet to really disrupt how we do things clinically in any ways. Yes, there might be some algorithms that are now being tried in your hospital for imaging either interpretation or generation of documentation, the X-ray notes and stuff, but they are still away from the bedside and away from disrupting how you do things at bedside, whether the stethoscope or the ambient AI transcriber are doing that for you. So I'm not going to put much time. We're still kind of, the AI is still blinded into what we see in our room. So our eyes become an arsenal for us to use appropriately, whether it's eye contact, whether it's actually diagnostics, whether it's just getting data that you cannot give the machine. I mean, you can, from your eye, assess their mental status, their even psychological situation, reading the room, getting more context, the way the wife looks at them, the way the mother looks at. So you get a lot that it's hard for the machine to be able to even trained on to get from what you get from your eyes. So AI as a diagnostic tool. This is one thing I enjoy actually doing and using. I am one of these folks who used to Google a lot, and now I actually chat GPT a lot on the clinical encounters that I do. It is very helpful because it makes you open your horizon for a wider differential, think outside of the box, and also know more about what you're dealing with because you know what? You don't see all the problems in an equal amount. So you don't, this becomes a way for you to brush off on topics that you have not encountered for a while. And believe it or not, physicians are using it quite often. Out of three physicians are using AI on a regular basis. And this is 2024. And compared to 2023, that was up by 78%. This is amazing. This is an AMA survey that they actually looked at talking to 1,200 physicians. But what they're using AI is very important. So active diagnostics, basically, not a lot of folks are using it and it's not growing. Maybe 1 out of 10 will actually use a chat GPT like or some Claude or something to look at diagnostic or like the diagnosis in a sense. But documentation, oh, it doubled. Creation of discharge instructions, progress notes, doubled. Look at translation services, they're actually increasing by almost 30%. Summaries doubled. Everything else is like doubling because it's easy. It's a technology that actually saves you time, does not take a lot of uh, your main skills, and but they're still not actually using it in a way that is augmenting their clinical decision making. This is one thing that I'm going to try to also advocate for and show you how to do in real time. This is a nice systematic review of all healthcare AI applications using LLMs. And when you look at what people search for in these literature, they are so obsessed with accuracy. Look at it. It's 95.4% of all these papers all focusing on accuracy as a main measure. Uh, they look at other ones, but they really don't put themselves in a place to look more than like, okay, did I get the diagnosis right? How accurate was the diagnosis? So and so. So this, okay, did it read the note correctly? Did it transcribe correctly? Which in some application is the most important thing. You want your dictation system to get the word you're trying to say, not the word that the things you're trying to say. Put it in the context. So it actually helps, but it's not the only thing that you actually need. Deployment metrics is something that they really don't care much about, but this is the most important part. That can I put this in all the clinics, on all the hospitals? That's going to make this difference. Really, it's not something that they look at. Of course, bias, fairness, that's not something that they care much about. So there is this skewness or the obsession with accuracy, and for a good reason, but it's not the only thing you need to get out of the LLMs nowadays. And this is a nice study. It was looking at diagnostic accuracy of clinician professionals and LLMs. Okay, and they actually reviewed 30 studies involving 19 different LLMs, and they actually looked at 4,762 cases. So this tells you that look at this accuracy. It ranged with the LLM anywhere between 25% to almost 98%. This is scary to tell you, oh, I'm gonna give you an answer, but sometimes it might be 25% accurate, sometimes it's gonna be almost 100% accurate. And I don't know how to tell you if I'm reliable or not. And it's up to you to take that insight out. On average, the experts say 35% of the time it is not uh, uh, accurate. So that's still, I mean, almost it's like 2 out of 3 might get right and 1 out of 3 is going to get wrong. But again, you don't know which one of the three is doing that because it does not have this sense of how to weigh its uncertainty. So this is something that you need to keep in mind. And it, but when when you augment it with a clinician, you are seeing clinicians do better. This is a study that looked at residents and faculty and students without CDS, and this is actually a pre-LLM study. So before Claude and all these big systems actually were in, and ChatGPT, Hype, and everything. And they looked at it. Okay, if you actually Google something or use the computer to look at something, how much do you actually gain in terms of kind of the correct diagnosis? And the positive is actually putting a differential on that they didn't think of, and negative is the opposite actually. So actually, the diagnosis was actually ruled out by doing that search. And you see the net gain actually persists even to the faculty. It's not huge, a 3.3% gain, but it's almost 10% for the students. It does augment our decision support making, and it's very important. And you can see how it affects the positive side and the negative side. So you know that we are better doing Googling or ChatGPT or something. This consultation with technology is helping us achieve better results. And they actually try to look at LLM's models and see whether medical reasoning and why is it not working, or how can you improve it in terms of its cognition or metacognition. So there's a slide that's missing. Let me. Probably we're gonna get to it when we get to it, but this is basically was looking at different prompting, and we have a section we're gonna talk about how you prompt with LLMs and see how it actually helps you. So LLMs as a CDS, they can actually analyze patient data. They can go and search medical literature. They can actually give you clinical guidelines to assist, whether it's a European, the US, or whatever organization. They can give you a diagnosis list, recommendations. And ChatGPT 4 does actually improve your diagnostic performance, especially if you put labs. So the more data you give it, the more accurate it becomes. But again, who generated that data? It's not only the lab work, it's your clinical sense of saying this right word, using dyspnea instead of, oh, I'm winded, using this instead of that, knowing how to put this kind of piece of clinical data in the context. That's what makes it better. It's not them on their own getting better. It's your prompting, it's your search words, it's uh, the relevancy to medical literature that the patients might not necessarily have. They also have issues like every other AI, accuracy and reliability. We said it's not that great, and they do hallucinate. And we will have a talk about how what's the under the carriage or like, under the hood for LLMs and how they work. We should understand hallucinations better so we know when actually they get there and why they exist to begin with. Of course, bias and fairness. This is something that is embedded in medical literature. All our data are from young white males. That's how we validated our data. You look at lab values and you look at different countries, and they have completely out of the limit measurements. Same for weight nowadays. I rarely see a 70 kilogram person with a BMI of something between 20 and 25. All our patients are either too big or too small, and or somewhere in between. This is another issue of how you can actually be able to validate on them. The privacy and security, when you're actually feeding all these clinical information, are you breaching the data or the privacy of someone else? The black box nature, again, very hard. And this was looking at human AI collectives that looking at how they actually diagnose, and they actually found that the hybrid collective of physicians and LLMs outperformed physicians alone, either physician or a group of physician, and better than single or multiple LLM ensembles. So just using the combination is superior to even using five different LLMs together. The combination of human and machine wins. And this is a very important kind of the message to get and know that our role will still be very important going forward in healthcare. And this is the nice thing. This is the other slide that was missing. And this is when they were prompting, the prompt is the identifier role, and this is what they tried for. Your medical assistant trying to get an MCQ answer for a doctor. Then you actually say, okay, might be tricky. Believe it or not, the machine is sensitive to the cautionary signals you're going to give them. This might be tricky. Actually, it changes how they look at it. Double check your answer might actually change them. Use this type of resource instead of any type of resource. All these actually are helpful. So they had seven types of prompting, and they actually measure the accuracy of how they do on this clinical vignette set. And the full role, or the role full, which is the one before last, did the most in terms of total accuracy. And you can see the high confidence, mid confidence, and low confidence rate, and missing a recall answer. This was the most superior one. And it tells you with the same set of data, prompting does make a difference, and actually you will be necessitated to know how to prompt properly. So this is the prompting that I typically use. I tell the machine when I'm actually, before I put the case or ask the question, please answer this question as a specialist physician to a patient. So it simplifies the language. Use plain language that can be understood easily. Double check your answers and include hyperlinks to the sources. So it actually has to go and validate that from the source, not only just get a kind of a hodgepodge. Use only peer-reviewed scientific sources from PubMed. Put any differential diagnosis and recommendations in a bullet point, so it actually helps me see and navigate what it actually puts. And let me show you how the answer looks differently to an MCQ that I grabbed from online and throw to it to the LLM. So let me go to my, okay. So this is a plain case of 65-year-old male coming with 2 week history of shortness of breath, with exertion, reported productive cough of clearing sputum, significant past medical history of smoking, hypertension, exams with crackles, lower lung field, JVD. Was the following the most likely diagnosis? And you can see it actually step by step. This is without any prompting. It kind of broke down, put you in the differential, give you the most likely diagnosis, and tell you, oh, like a throw off part of the history that just there to kind of fool you. It's not actually so. It does that, and it did it very quickly. When I use my prompting, I said, please, blah, 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 and give the same case. It took 3 minutes, but it looked at 23 sources. And this is what you need to do with complex cases, especially when you're talking about something that is a case report level of complexity. And this is what you guys deal with, subspecialists. And this is what I deal with as a subspecialist. Okay. It came to the most likely diagnosis correctly. It actually outlined what was the most appropriate part and gave you the recommendation, where actually got the data from PubMed, actually ruled out an infection in a way, but also said what can just infection can trigger heart failure flares. Give you a differential to actually to think outside of the box and told you what workup to do, and also give you a recommendation. Now, yes, they both gave you the right answer in the context of the things, but look at how here we just like throwing stuff at you. And yes, give you a most likely diagnosis, where here it started with the diagnosis, explained the logic, and then gave you data for each point that actually thought of that is coming from a source that you would be able to go verify and trust. And this is why I think one of the most important things we're going to be learning in the future is language. I mean, humanities are going to have a renaissance now because this is all we use to train, and this is all the machine uses to learn. And optimizing our language and the machine's language is going to be amazingly important in the future. So keep in mind that you should try to build your own prompt when you do that. And then when you do this, now every time you put a question here, it will answer in the same manner because the prompt will carry forward. Now, there is forgetfulness with these models. You might actually have to say, please make sure that you go back and remind them of this uh, prompt here, but it will actually remember it for a few steps after that. So if you're actually in the same session, it will probably carry it forward for at least five times or 6 times. It does not hurt to actually go prompt it again. It just takes much more time than it would have done. Look like the steps that it did to get to the answers that it gave you eventually. Now that's a laboratory research that you want to do before going to a patient with a complex decision and making it. And this took 3 minutes, and I'm sure it's going to get shorter and shorter with time, and especially as you actually keep using it on the same patient for the same prompt and the same kind of case diagnosis. Now let's go back to here. So prompting does matter, and we showed you with this study how prompting actually improved the accuracy, not only 73% to 78%, but actually the high confidence. You can see which one better, and also missing answer recall, where you can say the answer might not be there, so it's not going to fool you for the wrong answer. This simple prompting of saying there might be fooling stuff or tricky stuff or missing answers improved at outcome in saying this is something I don't know, which if you remember from my first lecture, this is our strongest suit to know when we don't know. And this is something that the machine will be able to sense when it's actually being prompted properly with guidance into where to look and what to look for, and that might be looking at something that is not there. Oh, let me go back. Okay. Now, administrative part of our job is also something that AI is coming to disrupt in a significant way. So we have data quality issues with how we keep the simple kind of billing and coding data. So this was looking at 32 studies that included how data we collect for administrative clinical registries and other stuff. And the accuracy of it was 80%. 80% might be looking good, but you're missing 20% of the data that you should be having in your discharge summary or in your ICD-10 codes or whatever. That's a lot. That's 1 out of 5 diagnoses being missed or underreported or wrongly reported. So 1 out of 5, now, when you put it that way, that's a big number. And actually, it comes at the cost of money that you would have claimed or malpractice that you should have avoided by just having that diagnosis clearly documented there, which you didn't. So AI billing and coding is going to have a huge improvement, increase efficacy and accuracy, efficiency, sorry. It will increase the cash flow for any person who's using it because now you're capturing all the diagnoses and even stuff as procedures that you would have documented but forgot, and also will help you with your data analytics in the future because it's captured in a more detailed, more way, like a specific way than you would have put. Like we go for the shortest cut. Like when I'm putting the differential, like I don't try to click to the sub kind of category of the ICD-10. I just put whatever ones comes first to me because I need to move on and do the next thing. The machine here is doing that for us, so it's higher accuracy. These are billing encoding platforms that are US specific. Debra is another one that actually we talked about, which also transcribes. And this brief description, their cost anywhere between $100 and up to $150,000 per month. So a lot of money is actually attached to this because they know they're bringing you money. So they actually are asking for their worth, or at least what they think they're worth. These are actually Canada-specific platforms for billing and coding. You might actually want to, when you get the slide PDF, view some and consider if you are in a private practice or you're going to go to private practice or you're going to recommend or for your institution to look at some of these. And again, I have no financial interest in any of these. I don't have any relationship with them. I'm just putting them as a reporter on what technology are there and who's doing what. And it's important for you to be able to look at them and validate and choose if you're going to choose to go with any of these solutions. Now we're wrapping up to the most important part of this talk. We are not just data administrators. We don't necessarily only rely on data for our differential diagnosis in our clinical decision making. There is things that are way beyond data, and you know it, and I know it, and machine does not know it. If I'm recommending something to a patient who is actually sitting in Syria or in Afghanistan or in Kenya, it's a very different set of recommendations and workup steps that I would do if this patient is actually in the ER in the US. And this is something that machine is not sensitive to. That is basically because I understand that after I get the classification part right, I need to operationalize that. So going back to these steps, these are the interpretation of what the algorithm has thrown at us into an actionable item and something that you actually then go and be able to build into the machine sense is really, really hard. And again, we deal with very complex situations that every case is a case report in a sense, and you are documenting a case report every time you write a progress note in these patients. And this is the nature of medicine. So yes, the final diagnosis was CHF, but they come from so many different pathways to that the same diagnosis eventually. But eventually, we need to know that this is actually a very human intense job. And the most important part, that the doctor-patient relationship that involves vulnerability and trust cannot be replicated by an algorithm. They don't want to hold hands with a machine. No one wants to do that. They want you to be able to use technology to give them the best care. They don't want you to become a robot. That's the first thing any physician or any patient wants to see. And that's so. And again, I love science. I love data. That's why I go to data science. And I think medicine is a science, but caring for a patient can never be but an art. And with that, I actually conclude my lecture, and I can show you how funky and stupid the AI generation. This is me saying, imagine me as a cyborg, and I don't look like this, not anymore. So thank you, everyone, and we have a few minutes for questions. So please open your mic and we can have some questions.
Thanks, Abdullah.